A 33-year-old female presents with amenorrhea, palpitation, heat intolerance. On assessment, a diffusely enlarged mass was found in the central part of the neck. The mass moves with deglutition. Biochemical assessment of the thyroid functions were found to be T4, it is 20 micrograms, TSH 0.22 micrograms. So this is a case probably of hyperthyroidism, and this is due to Graves. Actually, this line has not been added. All except are true. So all except are true for this case. Now, when we talk about all except are true, so this is a case of hyperthyroidism, and let us see this thing. How do we see hyperthyroidism? What are the classical features? And then we will see the options associated with this. So when we talk about the current scenario, the features, the patient presents to you, the presentation is amenorrhea. The presentation is, along with that, palpitations. The patient presents to you with heat intolerance. These are classical features, and along with that, weight loss, which is not mentioned here. They are classical features suggestive of what? The hyperthyroidism. And then if you see the biochemical profile of this patient, you'll understand that there is increase in T4 and there is fall in TSH. So now you are dealing with a case of hyperthyroidism. Now, what are the causes of hyperthyroidism? Let us see. When we talk about hyperthyroidism, there are two important categories. One where the gland itself is producing excess hormones. So that is the case where there is increased radioactive iodine uptake. So why you say that increased radioactive iodine uptake? Because if actually the gland is functionally active, it will accept more and more radioactive iodine. And then there is a category where there is decreased radioactive iodine uptake. Now, how is this possible that the gland is having excess production and gland is not accepting? So here the case is not hyperthyroidism due to excess production. Now, this is a category where maybe because of thyroid stimulation or an injury to the thyroid, all the stored thyroxine, or you can say T3, T4, has been suddenly thrown into the blood, and thus there's a surge in the levels. And that is why if you give them radioactive iodine, they are not metabolically active, so they will not accept. So these patients are the patients of chronic thyroiditis, chronic lymphocytic thyroiditis, or you must have heard of subacute thyroiditis, that is de Quervain's. So chronic or subacute thyroiditis. Apart from this, it may be due to factitious thyrotoxicosis. What is factitious thyrotoxicosis? The classical example of factitious thyrotoxicosis is someone advised to take 40 international units and you took 14 tablets, or you took 40 tablets. So you have altered the facts. That is why it is factitious. It may be due to allergen induced, and that is what is hamburger's thyrotoxicosis. So hamburger's thyrotoxicosis. Now, when we talk about increased radioactive iodine uptake, the patients with increased radioactive iodine uptake, we have Graves' disease. And this is also diffuse toxic goiter. Then we have Plummer's disease. That is toxic MNG. Then we have solitary toxic nodule. Then we have dyshormogenesis. Then we may have it during a condition which is known as dermoid, teratomas. So struma ovary. Or you may have it because of some tumors, which is even though rare, but it is. Let us see the options. Graves, if you talk about Graves, It's an autoimmune origin. Yes, it's an autoimmune condition in majority of the cases. In more than 80% of the cases, it is autoimmune. Toxic adenoma is associated with GSP mutation. Do you know solitary toxic nodule or toxic adenoma? When we talk about solitary thyroid nodule which is toxic, the problem is that this nodule is auto functioning, and the reason is that there is something which is known as G stimulatory protein mutation. Now what is this G stimulatory protein going to do? There is gain of function. There is gain of function of G coupled protein on adenoma, and that is why there is uncontrolled increase in size. When we talk about surgery is preferred over radioactive iodine ablation in toxic MNG, this is a very interesting topic. Now, do you know that in Graves' disease, the entire gland is at fault, but in toxic adenoma, there is a nodule, and in toxic multinodular goiter, there are multiple nodules. So, if I want to ablate them, the dose of radioactive iodine required will be very high. So it's a high dose, and do you know at this high dose, this normal thyroid parenchyma is also exposed, because this is also metabolically active region. So normal thyroid parenchyma, this is destroyed, or you can say this is inflamed, and this is known as, there is a collateral damage induced which is known as the radiation induced thyroiditis. So thus, since there is an increased risk of radiation induced thyroiditis, we refrain from the radioactive iodine as a first line option in case of toxic MNG. So this is what. So point C, point B and point A, they are all correct. Surgery is the preferred management for apathetic thyrotoxicosis. Now, apathetic thyrotoxicosis is seen in elderly with subtle features, with cardiac anomalies, with you can say cardiac abnormalities. So all the frank features of hyperthyroidism are not there. They're the patients where cardiac abnormalities are the only whole soul presentation. Along with that, they may be having non-specific features like depression, myalgia, weakness. And then if you see the biochemical parameters, you get to see a maybe subclinical hyperthyroidism. Now, this is a patient where radioactive iodine is preferred because of their age and the medical comorbidity. Surgery is intolerable for them. So, there is a case which is reported as apathetic thyrotoxicosis, where in elderlies, the overt features of hyperthyroidism like heat intolerance, tremors, everything is missing. We have non-specific features. Along with that, we have cardiac instability in these patients. So, these patients are never a candidate for what? Surgery. So, option D is absolutely wrong. Option D is wrong. Let us talk about one more interesting question.